Mhm.
The so I'm gonna put your telework stuff in. You're good because
Okay.
I'm just gonna
Oh,
count
for
your
real?
DCF. I'm gonna count your DCF time.
Oh my gosh.
Or it's
Really? Oh my
all right.
gosh. Thank you. I appreciate it.
mayor and members of the Houston Police Department and the Houston Fire Department.
Benefits, but you won't know unless you, one, call the number on your screen, two, give the
You want to go boarding shop? I have my boarding pass. Boarding pass. It ticket. Yeah. It ticket from the restaurant. It ticket. Yeah. Oh shit. That's.
All right, folks, we're going to give it one more minute just because there's a couple people that had issues with the waiting room.
Okay.
Do you think we should put the paper on top as well? So it
All right, folks, in the interest of time, we'll go ahead and get started. Tina, if you don't mind just taking over any of the admin functions, that'd be great. All right, so just to make sure everybody's in the right place, right? This is the Housing Supports Program and Provider Readiness Grants Overview, a partnership between the New Jersey Department of Human Services, New Jersey Family Care, and the Department of Community Affairs, Office of Homelessness Prevention, right? All right. So as far as what we're going to talk about today, right, this presentation is going to be facilitated by three folks, right? John Tu, Policy Director for New Jersey Family Care. Tristan Gibson, one of the other leads over at New Jersey Family Care, Office of Innovation. Myself, right, Michael Callahan, right, Director of the Office of Homelessness Prevention. And we're really going to talk and dive into 5 things, right? Just as a order of housekeeping, right? Please keep yourselves muted throughout this presentation, right? Renee Kubiatis, the Senior Policy Advisor for our division, will be minding the chat to record any questions that happen as your any questions that happen to come up or any other issues that require any addressing, right? That being said, right, please make sure that you are entering, right, those questions into the chat, and that any other issues or one of the things that we will be addressing questions is at the end. All right. So particularly, right, some of you, depending on if you came at Monarchs, if you just came off of Monarchs conference last week, or if you come off of a couple conferences, right, one of the things that we're doing throughout this is we're doing kind of a phased introduction where we give folks more and more information altogether, right, as we get closer to the launch date, right, and that's really on purpose, right. This is going to be a transformative moment in our ecosystem, right? And particularly, this is going to be not only one of great change, right? But there's also a good amount of risk, right? And because there is a large amount of risk with this, right? And there are quite a few executives and also 2 board members on this call, right? We really wanted to have a purposive conversation a little bit later towards this, right? On what are some things you should be considering at the executive level as you dive into, right, this program. All right, so in order to give kind of an overview, right, of New Jersey Family Care, the 1115 waiver, what it is, and the Housing Supports Program, I'm going to pass it all over to John Tu.
Great. Thanks, Michael. Morning, everyone. As Michael said, I'm going to go through a bit of an overview of the housing supports and where they sit within NJ Family Care and give you sort of an update of how we see those being delivered. I will sort of give the caveat up front that some of these things are still being finalized. So when you hear from us something that maybe is a little bit higher level than the detail you will need, just know that that is coming, rapidly coming in the fall as we work towards a beginning of first half of 2025 launch. So wanted to back up just a little bit where these housing supports fit within our larger Medicaid program. So New Jersey Family Care is another name for New Jersey's Medicaid program. That is, for those who may not be aware, Medicaid is a federally funded, state-funded partnership that provides health care to those in New Jersey and around the country who can't afford it. In New Jersey, we have 1.8 million members in our NJ Family Care program. It's about 20% of New Jersey residents, and they are served by our 5 managed care organizations. Much of our membership, something like 95, 90, 98% of our membership is in a managed care organization, and that will become relevant when we talk about the housing supports, as those will only be delivered through the managed care process. And then just note at the bottom, it is a pretty comprehensive health coverage program that Medicaid provides in New Jersey. This is everything from doctors and hospitals visits to prescriptions, dental care, mental health care. We pretty much run the gamut. So then within the Medicaid program in New Jersey, we have gotten permission from the federal government through what's called an 1115 waiver. Basically, every state designs their state plan around Medicaid from the menu of things that the federal government allows. So you pick and choose the pieces, you put together your state plan. If you would like to do something outside of the menu, you need a waiver of authority. And in this case, there's a ton of them, and we won't go into all of them, but in this case, New Jersey has used the 1115 waiver process to get permission to do something which CMS and Medicaid, CMS, the Center for Medicare and Medicaid Services. I always have to de-acronym myself. So in this case, CMS has given us permission through the 1115 structure to do these housing support services. That vehicle, you may have heard in other contexts, is how we're moving behavioral health into managed care. We have several pilots around maternity care, nutrition, community health workers. So a lot moves through that 1115, but these housing supports is a big piece of what's coming through that. In terms of the housing supports, the 1115 authority comes in 5-year chunks. So beginning in April of 2023, we received authority to begin planning and implementing this benefit. Our authority lasts until June 30th of 2028, at which point we will need to renew that authority. It's not that we expect 2028 to be the end of our housing work. It's that in 2028, we have to renew that authority and get a renewal. We're on our 3rd 1115 renewal, so I don't anticipate any issues with that, but it is a deadline that everyone on the call should be aware of. Great. So then on the next slide, the specific parts of the housing support program. Wanted to go through those one by one quickly. So the goals, of course, many health challenges that our members have cannot be fully solved or fully addressed if they are also not in stable housing. So the goal of this is to find and maintain housing for those of our members who are housing insecure and directly connect that to improvements in their health outcomes. As I mentioned, this is 1115 authority, and it will be statewide. We're not rolling this out in chunks or in phases. This will be, when it begins, statewide in New Jersey. Our services, which we will get into each of these sections a little deeper on slides that are upcoming, but the services briefly are in 4 buckets. We have pre-tenancy services. Think of sort of case management to help someone find a home or get ready to apply to get into a home. Tenancy sustaining services. What can we do to help maintain a member in their housing situation so they don't become housing insecure? And then residential modification and remediations. This is something that we do already for some of our managed long-term services and supports programs, but these are repairs or modifications to the home that could help somebody achieve their health goals. And then there's move-in supports. This would be those costs that come with getting into a new unit. Some of those are going to be able to be covered and paid for. It's in red. I got to say it. I will say it again. It's very confusing, and I'm sorry, but this does not include the payment for housing production or rent. We did not receive authority for that from the federal government. You may have heard other states that did. We did not, and New Jersey Medicaid does not include the payment of rent in these housing supports. We'll say it again because it can be very confusing that we're paying for many of these housing supports, but not all of them. Eligibility, as I mentioned before, this is only for our managed care members. That is 98% of our population. So it covers almost everybody in Medicaid, but you do have to be enrolled in a managed care organization to receive these services. And you have to meet one of both the clinical risk factors and the social risk factors. And we'll get into more what those are in future slides. Provider qualifications. Who do you need to be to end up as a provider of these services? Pre-tenancy and tenancy sustaining services we've bucketed together. We'll get into this again later, but think of organizations that are already doing this work. This is more about just getting those organizations to join the managed care networks to provide those services. Modification and remediation services, think licensed home contractor. And then move-in supports can be delivered by any of the above, whether it's the managed care organization themselves or pre-tenancy provider. Any existing provider for a different service will be able to provide the move-in supports. And then finally, this is important to say that our administrative model, we have pretty clear goals for delineating the roles in this. The managed care organizations are responsible for building out a network of providers. They're responsible for paying claims and authorizing those services. And they're primarily responsible for making sure that the housing experience of the member is connected back to the behavioral health and clinical health, physical health of the member, so that if housing is driving a physical health issue or vice versa, that those are all connected in a place where they can be dealt with holistically, so that we're not sort of siloing the member's care. That's a crucial piece that we expect the MCOs to do. And then housing supports providers, they're delivering the services. We don't want the managed care organizations delivering services and the housing supports providers getting into authorization. We want these delineations to be pretty clear so that the housing support providers can focus on what they do best, which is delivering those housing services. Okay, so on the next slide, I want to give sort of an overview of the pathway that we expect a member to take. So this is identification and service request is that first place. We are targeting a no wrong door approach. So if a housing services provider is already engaged with a member, they can send a request for service into the MCO. A member can send their own. A provider, a primary care provider could send in. We want the managed care organization to be able to receive these requests from anywhere. And that includes whether it's a portal, fax, phone, we truly want this to be no wrong door. We will then move into the eligibility assessment and service authorization phase. This is where the managed care organization makes sure that the member is eligible, that they're connected to a provider. The MCO will authorize the services in this step. Next up would be the care planning. And this is where I talked about connecting back to that behavioral health and physical health. This is not something that's required. If a member would like to opt out, they can. We certainly see it as a very important piece for both the providers and the member to make sure that their care is being coordinated, but that is not a gating step, not a prerequisite. And then service delivery. The provider gets notified, services commence, all the way through to the end of when services are needed and no longer delivered. So that's sort of a high level version. And then want to start drilling down into these pieces. So on the next slide, wanted to go a bit deeper on each of the 4 services. And I will call out at the beginning here that I'm not going to read through each thing, but I'll try to give an idea of what each of these 4 buckets includes. We have much more detail in a services dictionary that will be released. As you can see in the top right, that's still pending approval from our federal partners. So everything here needs to be taken with that slight grain of salt, which is that until CMS has officially approved the services, we don't have the quite all the way down to the service level detail. But to give you, we have a very good idea of what the 4 buckets are, and they're here. Pre-tenancy services that I mentioned before, this is anything that needs to be done to get somebody ready to move into a home. Finding a unit, working with someone to get an ID so that they can apply for a voucher or apply for a unit, all those sorts of things that connect members to other resources that are needed or to take care of sort of prerequisites to getting into housing. Then there's the tenancy sustaining. This is primarily an individualized housing support plan to help the member achieve their goals. And those goals are focused on keeping someone in the house, whether that's assisting with resolving disputes with landlords or connecting the member to resources that they might need to make sure that the member can stay in that house. Then the move-in supports. These are a little bit amorphous because it's going to depend on the situation, but basically the setup of a new housing unit, the moving costs that are associated with either moving from one housing unit to another or moving from a situation where they're not in housing to a unit, those sorts of things are covered under the move-in supports. And then the modification and remediation. And this is things such as air filtration, asthma remediation in the case of remediation services. And in the case of modification, think ramps, handrails, grab bars, those sorts of things that make a house more livable as someone ages or as someone deals with maybe some health issues. Those sorts of things that keep someone in the home, those will be covered under the modification remediation. So on the next slide, this drills a little bit deeper into who we expect these housing services providers to be. On the far left, we've got the 4 services laid out and sort of mapped against, as we proceed to the right, who we feel these service providers will be. If you were to say, I'm an organization now that's doing X, what's my role in this? Hopefully this helps. This is by no means set in, this is not, if you're a home contractor and you want to get into tenancy support providers, this doesn't mean you can't, but in terms of the things that providers are doing right now, this is what we expect to see. So both the pre-tenancy and the tenancy sustaining services, those will be the tenancy support providers. Think shelters, permanent supportive housing organizations, case management organizations, those organizations that are doing this work now. They may not be calling it tenancy support or pre-tenancy services, but those services that we listed before, those are the organizations that are going to be doing this. Home modification remediation, as I said before, think home contractors. We already do have a fair amount of home contractors that are working with our managed care organizations for our discrete MLTSS population, but that will be expanded to a broader set of members there. And then the move-in supports, as I said, can be delivered by any of the providers in the previous 2 categories, or even the MCOs if that's the way to deliver it. So that's a good example of the housing providers. Let's move on to the eligibility criteria. So as I mentioned before, you need 3, as a Medicaid member, you need 3 eligibility hurdles basically to qualify for the housing supports program. The first is that you are enrolled in an MCO. That's a hurdle that most of our membership meets, but it is a requirement. So MCO population, then you have to meet one of the social risk criteria that are laid out here: at risk of homelessness, at risk of institutionalization, transitioning from an institution to the community, or recently released from a correctional facility. You must meet one of those 4 social risk criteria, and you must meet 1 clinical risk criteria: chronic health condition, mental health, pregnancy, needing assistance with activities of daily living. I won't go through them all, but that is the type of thing that you need in a clinical risk criteria. As I said, and I'll say it one more time, you need 1 clinical risk criteria met and 1 social risk criteria met to be eligible for the housing services as a Medicaid member. In the top right, just want to call it out again. This is another place where CMS's pending approval is going to be important. We think we have a near final list of all of the clinical risk criteria, but until we hear from CMS with that final stamp of approval, we do need to talk about it in the conditional. So then on the next slide,
Well, John, for a second,
Yep.
could you just go over real briefly for folks the diagnostic criterion for that and how it's a little more expansive, right, than a formal diagnosis too?
Yeah, that's thank you, Michael. That's a great call out. So when you see these broad categories on the page, first of all, once we have CMS approval, we will have much more detail for you underneath those of what those mean. But also Michael's right to call out, this is not something where we are going to require a housing services provider to document a mental health condition or require that a diagnosis have been made in the case of mental health. So these are places where you will see throughout the process as we lay out the member journey and the MCO authorization process, that these are something that members will have to attest to. There is varying levels, and I think in many of them, lower levels of diagnostic information that would need to be provided. In the case of a housing services provider, you are talking to the managed care organization, who is the one that has a lot of the members' health information. We're not going to be requiring the housing services provider to be dealing deeply in the members' healthcare, especially when we're talking about things like mental health that might have even higher risks around sharing information. So this is a place where we have a lot of upcoming guidance for managed care organizations as well as housing providers of how to deal with that. But just at this level, I think it's important to focus on the fact that there will need to be a clinical need in the member to justify the housing services. It will not be the sort of thing where we're expecting housing providers to get into the medical information of their members or of their clients. Does that sound good, Michael? Anything you want me to hit there that I missed? No? Okay.
No, I think that's perfect. Yeah, there was just a
Okay.
couple at the front end.
I appreciate that. That was a great call out. So then how do you become a housing supports provider? I think I will start at the bottom with this box. We recognize that what's on the page is not enough to begin becoming a housing supports provider. This is to give you a broad outline of what is coming. We will be releasing more guidance on the enrollment and credentialing process in the fall. Also, with that, please do not start any of these steps. So as I go through, I will talk these out, but if you start them now, the managed care organizations will not know what to do with you. They do not have the guidance they need to get their system set up. So if you approach them for more than a connection, they will not know how to get you credentialed because we haven't told them yet. So please be aware that these steps are coming, be aware that more guidance is coming, but except in the case of a couple of specific things that we will outline, don't start doing these yet. They're not ready for you. So how do you become a housing supports program provider? First, and I think Michael will get into this a lot more, conduct a self-assessment. Look at your organization and see, is this the sort of thing I want to take advantage of? There are definite pros, and I think there are some cons to be considered for an individual housing supports provider as to whether they want to join managed care networks and deliver housing services to Medicaid members. So self-assessment. Second will be to get a national provider identifier known as an NPI number. This is a 10-digit number. It's ubiquitous in healthcare, but maybe not so much in housing services providers. The application process is pretty smooth. Again, it's not ready for you yet. We have some information to deliver to you about what categories you should apply for to get an NPI, but you will need to get an NPI. Third step, enroll with the Division of Medical Assistance and Health Services. This is NJ Family Care, us at the state. You need to enroll with us. This will be a fairly light touch enrollment, what's known as the 21st Century Cures Act application. This will be a light enrollment, after which you can then credential and contract with the managed care organizations. And that will be the step that actually gets you into their networks. We're now on the far right. That is the part that will actually get you into their networks, enable you to deliver services to clients, get the authorization for those services, get reimbursed, get paid for those clients. I will call out in the last two that the regional health hubs, and we will say more about that role later in the slides, but the regional health hubs are here to support you on both the enrollment with us in 21st Century Cures and the enrollment with the managed care organizations. So you will have some support as you work through what is a admittedly new process for many, if not most of you. Okay, so then I am going to pass it off here on the next slide. I will briefly say that we have two large buckets of support that's coming your way. The first are the provider readiness grants that Michael's going to talk about right now. And then the other is what I just mentioned about the regional health hubs being online to support you through all these processes. So Michael, let me turn it over to you to talk provider readiness grants.
Awesome. Thanks, John. Right. All right. So particularly, right, just as a brief high-level overview, right? So DMOS and DCA are partnering to distribute the provider readiness grants to eligible housing organizations, right? And importantly, the reason why we're doing this is that we know very well, right, that the nations throughout the state that are providing rapid rehousing, that are providing street outreach, that are providing emergency shelter, right? Many of you are not set up to bill Medicaid, and it may have been on your radar a little bit if you were going to stand up a substance use program or a behavioral health program, right? But for the majority of folks, it hasn't really been in their wheelhouse, right? So importantly, right, at baseline, one of the things, so John went over a bunch of things that to tee up so you have awareness of doing, right? One of the things that you should be doing right now, and don't worry, these slides and the takeaways and some other things will be distributed immediately after the presentation, right? Is that we want you to prove engagement with at least one MCO through a letter of intent, right? And so if you look at the people, right, if you look at the people that are on the screen over here, and their email addresses and those points of contact, right? You want to reach out to these folks in order to begin the process of obtaining and executing an LOI, right? I can say, right, it would behoove you to do with all five, right? But just for the purposes of the infrastructure grant, the provider readiness infrastructure grants, right? You only need one LOI executed, right? And the flip side of that is also too, right? The provider readiness grants aren't going to be for everyone, right? There are some organizations, right, that are already billing Medicaid for, various other things. So good thinking about like Bridgeway here or CSB&J, right? For those folks, right, there's not going to be the activation energy in order to go and start doing this. Similarly, right, if your CBO is of the entrepreneurial bent, right, and you think you can do this without the infrastructure spending, there is no requirement for you to participate in the housing supports program through New Jersey Family Care that you go after this infrastructure funding, right? So just want to be really clear on that, right? So when we look at the infrastructure supports for community-based organizations, right, the organization that we're targeting here, right, is a housing or homelessness community-based organization, right? And the intent is that through your assessment, and we'll go through, right, the conversation that you should be having with your board. An example of that, right, is you as an organization have come to the realization, right, that you are not ready to join the provider network due to infrastructure or ramp up requirements, right? But through these infrastructure support program, which provides three different categories of funding, right, being seed capital, program readiness dollars, and flexible funds, right? Through this 1 year process, right, you will be able, or sooner, right, over the course of 1 year, after you go through this process and leverage this funding to do so, right, you as a provider will be ready to enter the program and to be receiving and providing services to members of New Jersey Family Care, right? So when we look at these buckets, right, each one of the individual infrastructure grants has a $250,000 ceiling, right? That's the absolute maximum. This is going to be a cohort-based competitive process, right? Right now, we're looking at anywhere between 25 to 60 in the initial cohort, right? Depending on the responsiveness. I mean, we've got north of 300 people on this call from that many organizations, right? We may move, right, upon realization to, instead of having this be a yearly process, to be every 6 months, right, working out a new tranche of folks, right? As part of this is just as we're asking you to do quite a lot and pivot around, right, and be flexible, we're doing this too, right? Simultaneously, the infrastructure support funding is going to be milestone-based reimbursement, right? So, right, if you're already a grantee of my office, right, many folks are used to all right, you get an advance, and then you start submitting FSRs, which bill against that cash on hand, and then you can get a second advance if your kind of runway is looking a little short, things like that, right? With this, right, instead the performance indicators are, right, you're going to meet certain criteria, and once you meet that last milestone, right, you are issued the next advance, right, in order to start spending down that cash. Importantly, this more rapidly deploys, right, funding to make sure that it's leveraged, that you can leverage it appropriately. But also too, right, this really lets you kind of to the speed at which you can operate as fast as possible for some folks, and for some folks it's going to be a little more deliberative, right? You'll be able to operationalize that capital as it's deployed. Right. So when we look at the first eligible categories of funding, right? This is really for seed capital, right? And so when we think about seed capital, it's the same way as you was kind of conceptualize a startup or kind of a nascent company, right? Your pre-seed or seed round is really to get you so that you can start figuring out, okay, right, do we have product market fit? Right. And in order to get product market fit, we need to expand beyond our existing portfolio of services, right? And so the eligible activities for here, right, are staffing, so hiring and recruitment, equipment and supplies, some initial IT infrastructure, preliminary training, right, short-term operational costs, but most importantly, consulting services, right? And these can be organizationally developmental, or they could be financial, right? One of the things that we're going to talk about as we go into the board conversations are many of you in your organizations, your revenue cycles are grant-based, right? And pivoting over from a grant-based reimbursement cycle over to a fee-for-service or just a reimbursement model, right? It could potentially be very disruptive, right? And so we want folks to be really deliberative as they go and think about it, right? And that also being said, right, the idea with this, right, is that through this funding, which is really quite generous, right, you can go and engage with a McKinsey, you can engage with a BCG, you can engage with a Dahlberg, you can engage with an entity or even a KPMG, an entity that is going to be able to go and really drill into your finances, work with your board, work with your executive teams to go and say, hey, we're going to go do a thing, and these are the processes, this is the concept, and this is how we operationalize it in order to achieve that. Right. The second bucket of funding is program readiness, right? And that's kind of that moves away from that far term to more like near term deployment, right? And this is the idea. This bucket of funding allows you to build capabilities to operate as a Medicaid provider, right? It is less conceptual, it's more operational. And so the eligible activities here, right, are Medicaid enrollment, so managed care organization contracting and credentialing, right? Specialized IT systems, Medicaid-specific training, compliance measures, right? There's quite a few organizations throughout the state, right, that, you know, there's a paucity of just general kind of compliance, right, with regards to either fiduciary compliance or talking about compliance with regards to kind of more like CARF accreditation or things like that, right? MCO relationship building, billing and financial systems, and consulting services, right? And importantly, right, this consultancy services moves into, okay, right, how do we set our organization up for billing? Because we know that we understand that we can go do a thing, and now we are making that thing happen, right? How do we ensure that our middle office and back of house functions are really set up for that? Right. Similarly, right, it may be using some of this funding to engage with a legal consultant, right? But part of that is for many of the community-based organizations that are on this call, right, your general counsel is the attorney that's on your board, right? As you're doing your due diligence process, you're going to want to engage with a legal partner that can ensure that not only are you protecting your organization, right, but that you are set up to make sure that you're not exposing either your employees, your board members, right, the organization, or the people you serve, right, to any hazards. Right. And then lastly, the last bucket of funding, if you will, right, are flexible funds, right? And so one of the things we know is that we didn't want to be too prescriptive with deployment of some of this capital. And this really comes from lessons learned with our partners across the nation, particularly Oregon and North Carolina, right? And so the idea of this funding is that you have gone with your board and as an executive team, and you've come up with, hey, our ask in order for us to get to become a provider, right, really doesn't fit into those first two buckets, but we have a really well-defined process, and we have a couple asks that we can go and engage in that will get us there and ready to deploy these services and participate, right? And so the objective of these funds are to address the unique needs and innovative approaches that are unique to your organization. And so there's eligible activities that are examples, right? But they are more expansive than this, right? So this can be partnership development, community engagement, pilot programs, tech innovation, workforce development, capacity building for specific populations, knowledge sharing, or importantly, right, contingency planning. Right. So the key takeaways in understanding, right, right, what this program is going to provide, right, is that it's comprehensive support for organizations to, one, expand capacity, two, meet Medicaid requirements, and three, implement innovative solutions, right? And the focus on, if you're participating in these grant programs, and remember, right, the infrastructure grant programs are not a requirement to, right, participate as a housing supports provider, right? They are designed for those CBOs that are not ready yet, right? But in order to get across that finish line, right? And the idea is we're not too prescriptive, right, on the availability of funding or the use cases for that funding, right? We're really trying to emphasize the tailored approaches that will meet your organizational goals, but most importantly, that this is going to be a partnership moving forward, right? And so one of the things, right, so many of the folks on the call, just looking at who is registered for this call, they are already registered with DCA Sage, right? If you scan that QR code, right, or if you click on the link once the presentation is deployed, right, if you are interested in receiving, right, or going after these infrastructure support grants, which we're hopefully envisioning, hopefully here in the next month or so, right, depending on a couple of back of house things, right, to get up and opened up, right, that you're going to want to register your organization with DCA Sage, right? So Sage being green Sage, if you've been in the state grant making business for a while, right? It is not HUD Sage, it is the Department of Community Affairs Green Sage, right? Please click the link, right? And as we will have multiple sessions once we open up the RFP in order to walk you through a Sage application, some best practices and what that looks like, right? But if you aren't registered with DCA Sage, that's a process which can take about a week to do so. So we want you to get started on that now, right? And so now kind of pivoting over, right? Really the conversation, right? And so I've met with some organizations and some of their boards, right? And through this, we've kind of coalesced some guidance with regards to what you should be thinking about, right? And importantly, right, this framework's intended as a starter for your executive team and your board to begin thinking about this opportunity. But I don't want you to think that this is the only things, right? Is because OHP went and put this out, right? That these are the only things that need to be talked about. This is all we did, right? That is by no means meant to be exhaustive, right? So one of the first things that folks need to really be having a conversation with, both at their executive level, but also with their boards, right, is strategic alignment and assessment, right? So mission and capabilities fit, right? So take a look at your current alignment with your current mission and strategic plan, right? Does becoming a pre-tenancy services provider or a tenancy support services provider align, right, with your current mission and strategic plan, right? You should assess your existing experience with housing insecure populations, right? Do you happen to see folks experiencing homelessness, right, as kind of an adjunct to the primary service portfolio that you have? Or is that, right, your bread and butter? Is that the population you've worked with for a decade, right? And you really have subject matter expertise there, right? You want to review your current service delivery model capability, right? And whether that could scale or not. And that's really super important, right? And then you also want to look at you want to analyze the target population overlap with your current client base, right? For some of the more robust CBOs, right, homelessness services may fit into a niche of what they provide, but right, as there are certain overlaps, you may be able to drive efficiencies at scale because of that, right? So moving into service scope analysis, right, you really want to map the current services you're providing against the program requirements that John just articulated, right? Particularly looking at pre-tenancy services and the tenancy sustaining services. And similarly, right, once we put out additional guidance on that, you're going to want to redo those maps to make sure that there's alignment there, right? And in doing that mapping activity with your executive team and your board, you want to identify service gaps that are going to require new capabilities. And it's those new capabilities which are really going to drive, right, that decision point of do we go after this infrastructure funding or do we not, right? And so there's one key question that you should be having with your board, right? And that is, how does participating in this Medicaid housing supports program align with our organization's mission, enhance our long-term sustainability, and impact our ability to serve our community effectively, right? So that three-parter, you should be able to clearly answer that three-parter, right? Without any moral hazard, without any gray areas. You should have decisive, clear answers, right, to the three parts of that question, right? And so moving into an operational readiness assessment, which is kind of like a phase 2, right? And so taking a look at your administrative structure, right? So as your organization exists right now, do you have the capability to contract with an MCO? Right? Do you have clearly defined billing systems and processes? Do you have a strong data reporting infrastructure that is more robust than just the regular HUD compliance and putting data into HMIS in order to run a CAPER or an LSA or an AHAR or a HIC, right? It is going to require a very more robust data governance than many organizations are kind of used to already, right? Do we have a solid staff training program? Do we have quality assurance systems? Do we have documentation protocols and SOPs that are inspectable, right? And also, too, do we have IT systems compatibility, right? Looking at your staff requirements, right? What is our current staff capacity analysis? What are going to be the new position requirements if we go and do this, right? In doing a trainings needs assessment, right? What are the training gaps? What are our people good at? And what do our people have to get good at, right? What is our current supervision structure, right? Do we need another middle tier of management at an organization, right? And then what does our recruitment strategy look like if needed, right? One of the kind of longest time to delivery that we're seeing for the majority of grant programs throughout the state within the housing insecurity and homelessness space are the time to execution, because the staffing right now is pretty challenging, right? We're really trying to hit that point where we operationalize programs within 30 days of grant execution, right? And very, very, very often we're not hitting those timelines, right? So importantly, if you see gaps, right, in this assessment that you have, right, that's when you're going to drive and move towards the OHP provider readiness grant and or potentially another capital source to kind of overcome that, right? This assessment and this purposive conversation that you're engaging in, that should drive what the ask is for in the grant program, right? And then lastly, right, with our operational readiness, right? Looking at compliance and credentialing, right? So there's the MPI application process, which is very quick, right? There's the Medicaid enrollment requirements, right? Which John went over, right? And then there's the MCO credentialing requirements and documentation of housing support experience. What does that look like? And then compliance program adequacy, right? And so importantly, right, one of the things that I've been stressing in working with a lot of our partner agencies and a lot of our vendors, right, is that you really need to know and engage in deep financial analysis to know your COGS or your costs, right? So, right, your cost of goods sold and your cost of services sold, right? And these include indirect costs and direct costs, right? And importantly, in order to get to the number, right, where you not only break even, but this could be potentially a revenue positive activity that could support the other parts and be mission aligned with what you're providing, right? You need to understand your direct costs and your indirect costs. So this is a very high level overview, right? But direct costs have to be direct labor costs, right? So case manager salaries, housing specialist salaries, a portion of supervisor salaries directly related to service delivery, payroll taxes and benefits, and the materials and supplies, so program-specific tax costs, subcontractor costs, if there's any contractors involved, or other specialized services, right? Direct transportation costs, so whether your agency provides mileage reimbursements for staff travel, whether there's a public transportation cost for client-related travel that you build into your program, or whether there's a vehicle maintenance, right, for your staff travel, right? Training and certification with direct costs, right? So the costs required for staff training specific to this program, right? And then certification fees for staff which may or may not be applicable, right? And then there's your direct administrative costs, right? So the cost of running background checks and some of those back of house tasks that are pre-hire, right? And so when we look at indirect costs, we're really looking at those allocated indirect costs, right? So what are your facility costs, right? What is the rent or mortgage for your office space? If you're going to have to expand, right, your current footprint, what does that look like, right? And then usually a good way to do that is based upon the square footage that's used for the program. And then also utility costs, right, to include, right, your internet, right? Then looking at your indirect costs for administrative overhead, right? So your executive salaries, right? So your CEO or ED, right? This is going to require a decent chunk of his or her time. Similarly, your CFO, right? And then also looking at your bookkeeping and HR services and allocating that on a program share of the overall organization. Similarly, IT support and infrastructure, right? You should come up with a portion of costs that goes through that. And then looking at marketing and outreach, right? What are going to be the costs of this program-specific marketing materials? And what are going to be the outreach events related to the program that we're going to have to do in order to really drive that funnel to make sure, right, that if we're doing this, right, that as an organization, we're doing it and we're doing it well. So we have a solid inflow and we know our total available market, right? And so when you're looking at that, right, you get your total program costs, right, which are equal your direct costs plus your allocated indirect costs, and then you get your client cost per client, right? And that's your total program cost divided by the number of clients served, right? And this is as you kind of scope out what you're going to need in order to get there and to make sure that this is going to be fiscally tenable for you, right? These are the numbers and metrics you should be kind of driving towards, right? And so as far as KPIs and thinking about that, right? What are the direct costs as a total percentage of program costs? What are indirect costs as a percentage of total program costs? What's the cost per client, cost per service hour? Program revenue is a percentage of total program cost, and particularly, this is how you're going to measure sustainability, right? And so one of these things is, right, just as you start to do this and you start to go and figure out, okay, right, we're going to go after this infrastructure planning and we're going to deploy the tenancy support services and we're doing this over the course of a year, right? One of the things you want to go and do is you're going to want to work with your board and your executive team to review and adjust the cost allocations at least quarterly to ensure that there's accuracy there, right? Similarly, you want to look at this methodology and document it, and you want to understand the seasonal variations, right, to service delivery, right? One of the things that we know throughout the state, right, is, we are moving into high traffic season, particularly around unsheltered and sheltered homelessness, right? This is where we don't necessarily see a decrease in the at-risk population, but we do see an increase, a substantial increase, right, for both the unsheltered and sheltered populations, right? And one of the things through your financial planning that you should be doing is comparing your actual costs to your budgeted costs regularly to identify any significant variances. Right. And so in doing so, right, and thinking about that with your startup costs, right, what are the technology investments, staff hiring, train up, administrative setup, working capital requirements, and the provider readiness grants opportunities or challenges that you could address through the provider readiness grant, right? Similarly, ongoing operations, and that was that second bucket of services, right? What are the revenue projected based on expected volume? What's the cost structure analysis? What are our cash flow implications, right? MCO payment terms and timing, what does that look like? Because you need to bake that into your pro forma as you go and do this. And similarly, most importantly, what is your break-even analysis, right? So what are the number of people on a PM reimbursement rate that your organization is going to see at what price point in order to make this so you are at least revenue neutral, if not revenue positive. And then moving into risk, right? So as an executive team and at the board level, right, you should be having a substantive conversation around risk, right? So what are the operational risks having to do with service delivery capacity, staff retention and recruitment, right? We know throughout the state and throughout the services ecosystem, right, the number one predictor at an organization when you control for fidelity to certain case model are having seasoned staff being able to rapidly exit folks, right? If you have continual staff churn, right, your performance in this program is going to come out, and there might be accountability issues there, right? And that really flows into quality assurance, right? Do you have a solid quality assurance program? Because the flip side is, right, one of the things that this is going to do to the services ecosystem throughout the state is, remember, members have choice, right? So if somebody is receiving pre-tenancy services, right, this month at Bridges Outreach in Newark, but they had a really negative customer experience, right? They're well within their right to go find another provider in network, right? To go provide those pre-tenancy services, say CSP&J, or say Catholic Charities or something like that, and pivot over, right? So this idea that it used to be, okay, well, we're the only game in town and we're the provider, that's no longer the case, right? So many folks are going to have to take a hard look, right, at what our offerings are, but also too from a customer experience and user experience point, right? What does that look like, and what is the sustainability of that, so we're not churning folks, right? And we're really driving towards housing outcomes. Similarly, you want to take a hard look at your documentation compliance, right? If your organization struggles with entering case notes in HMIS more than 7 days after the fact, right, you're not going to meet the documentation threshold that's expected for this, right, in either timeliness or fidelity, right? And similarly, right, what are the risks to our organization from a relation management perspective with regards to the managed care organization, right? Are we a big fish swimming in a big pond with a bunch of sharks, right? What are we going to have to do in order to kind of insulate ourselves as an organization? And then also thinking about financial risks, right? Is our working capital adequate, right? What is our cash runway? Right? What are those things we need to know immediately, because that should shape, right, our risk tolerance for engaging in these activities. Similarly, and I hit on this before, what does our revenue cycle management look like, right? What happens if there's cost overruns? What happens if the contract terms aren't as favorable as we had hoped, but we have to engage, we have to leverage them? And then similarly, what assumptions are we making about volume with the number of people that we're seeing, right? Whereby we're actually right, the funnel we're projected that we would see 100 persons experiencing homelessness a month, right? But as it turns out, right, our staff can only handle 45, right? So what are the downstream effects of that assumption that we made, and what are the potential gaps there that we're going to have to go and change, right? And again, you identify a gap, that is what shapes your ask and the provider readiness grant. Right. And then lastly, and I want to be really, really specific on there, you need to be having a conversation with your board around the strategic risks of mission drift potential, right? So if you are a shelter and you are very good at providing sheltering services, right? If you are getting into this in order to find a revenue source, right, that might not be the answer, right? Similarly, right, if you are a just overall primary care provider or an FQHC, right, is it, oh, we could do this, but are you going to do it well, right? Importantly, right, this program has the potential to not only substantially change the way housing services are delivered throughout the state, but also this program also has the potential to accelerate outcomes to housing, right? And so not only does the board of your organization and yourselves as executives, not only do you have a fiduciary duty to the organization, but you also, as a nonprofit, you should be mission driven, right? And if your mission has changed to we chase after every funding opportunity that comes, right? You need to think about what's happening there, right? Similarly, right, what are the impacts on existing programs, right? If becoming a pre-tenancy support provider, right, becomes the shiny object in an organization, what happens to the organization, other programs that we've been running for 10 years that are very mature, right? Do they fall by the wayside, right? What happens with them, right? There needs to be a purpose of planning around that, right? And importantly, right, look at the competitive landscape, right? And when you look at your competitive landscape, that means you have to know what your organization's competitive advantage is, right? Some of you are in a very crowded market, right? Some of you are in a not very crowded market, right? And understanding and really being able to point specifically not only to a population, but as you address your total available market, right, of folks there, right? What are we going to focus on a certain niche population that we really fantastically deliver services to that allows us to differentiate, or are we just going to be more generalist, right? You need to be thinking about that, right? Similarly, regulatory changes, which may or may not come down the pike, right? And then also thinking about, again, program sustainability, right? And so when you move to implementation planning, these are what, could potentially be the critical path items, right? So as an executive of the board of one of these organizations, you want to know your board approval process. You want to go through them and make sure that you are partnering with them, right? Similarly, if you're going after the provider readiness grant, right? You want to make sure that your DCA SAGE registration is in good standing. Have you submitted your last audit? Right? You're going to need that audit. If you haven't activated or updated your information in DCA SAGE in 3 years, you're going to want to make sure that that's there. And you also want to make sure that your auditor submission is submitted, right? Similarly, right, there's a housing first resolution, right? Every organization that receives funding through the Office of Homelessness Prevention, that the board is required to submit a housing first resolution saying that you are a housing first organization, right? You want to make sure that you go and have an understanding of the MPI application, which can be done very quickly. There's a DMOS enrollment, MCO contracting, credentialing, staff hiring, system setup, and regional health hub engagement, right? Those processes, right? And of course, 3 through 8 really don't have to be done in that sequence, right? As far when you're envisioning what your critical path is, right? Those should be at a minimum, right? Those should be the milestones there. Right. And then as you think, right, particularly in working with your organization, right, with the timeline development, right, you want to be thinking about key milestones and what are dependencies on certain things, right? One of the things is in order to be credentialed with New Jersey Family Care and Medicaid, right, you have to have an MPI number, right? And so that sequencing that John articulated and you saw visually in that one slide, right, is really important, right? Similarly, right, with our resource allocation, right, what is that going to have to look like as we go after this opportunity? And most importantly, what are our go, no-go decision points, right? And what is the process by which we're getting there, right? And so when you talk about your key questions for board discussion, right, this is what they really should be, right? 1, do we have the organizational capacity to take this on while maintaining quality in our existing programs? 2, and we talked about this a little bit already, what is our competitive advantage in delivering these services? 3, how does this align with our long-term strategic vision? 4, what is our risk tolerance for the startup period, right? 5, do we have the financial resources to support implementation? 6, what partnerships might we need to develop? 7, how will we measure success? And 8, and this is probably the most important question you should be asking your board and talking about, right, is what is our exit strategy if the program doesn't meet our expectations or projections, right? So thinking about the next 30 days, right, if you haven't already been doing this, right, you should be forming an evaluation committee or have it formed, right? You want to complete the detailed assessment and what we kind of outlined there. You want to develop your financial models, create your implementation timeline. If you're the ED, right, think about what that board presentation is going to look like and ongoing, right? And you want to make a go, no-go recommendation for your organization, right? If you're proceeding, right, and as more guidance comes out, you want to begin the provider readiness grants process if that's what you're going to leverage, right? If you're of the more entrepreneurial bent or your organization is already well positioned, not to have to go after those funds, right? You want to make sure that you're initiating MCO discussions. And either way, right, regardless of whether you're going after the provider readiness grants or not, you want to engage with your regional health hub, right? So importantly, right, one of the things that we're asking everyone to do, both at Human Services and in DCA, right, is to fill out the Housing Support Services Program Survey so that you continue to receive program updates and so that there's contact information that can be shared with the MCOs, right? The slides will be shared later. You can scan that QR code now. right, if you want, right? And after this, right, I will be pivoting over to my good friend Tristan Gibson, who's going to talk a little bit about the regional health hubs and some of the training and troubleshooting supports that are really going to round out a lot of what we talked about. So Tristan?
Sounds good. Thanks, Mike. So as Mike mentioned, I'm going to go quickly here. I think to save time for some questions, but so we here over at DMOS, also known as NJ Family Care, are going to be offering 2 different items to help support provider engagement into the housing supports program. So we just obviously spent 45 minutes on the provider readiness grants, which will be capacity building grants released to organizations to help them integrate into Medicaid. The second opportunity that we will be providing are the training and troubleshooting supports, which will be administered through New Jersey's regional health hubs. For those who are not familiar, there are 4 regional health hubs in the state of New Jersey. They are regionally based in Newark, Passaic, and as well as Camden. As you can see here on this slide, they will be offering an array of supports to organizations to help them integrate into the program. There is going to be no application for this, no type of award system. These will be available to all and any entities who are interested in being a part of our housing supports program. So just really quickly, what are some of the functions of a regional health hub? They're going to be helping convene stakeholders and healthcare and beyond around state Medicaid priorities. They also operate a health information exchange. Regional health hubs also serve Medicaid and other state departments as local experts, strategic planning partners, and program implementers. And they also innovate on population and clinical health interventions in response to local needs. So these organizations are not a monolith. They offer quite a different array of services, including healthcare as well as housing services. So our goal in leveraging their expertise is to leverage their expertise across multiple different sectors within the healthcare and social services space to help connect with providers on the ground as well as members who will be eventually receiving these services. So that's really quick who the regional health hubs are. How will they be supporting our housing supports program? This is a very high level overview. We have much more detail that will be released in the coming weeks to months, but at a high level, some of the activities that they will be performing include delivering and curating trainings about the program, serving as a helpline for providers to help field and answer questions and troubleshoot issues throughout the process. So you could think of this as an email address or an actual phone line where you'll be able to call and email a central location to help answer any questions you may have about the program. So for example, you're like, oh, this, MCL, I'm having trouble submitting a claim, or I don't know how to submit a claim for reimbursement. How do I do this? This is the exact error I'm receiving. The regional health hubs will be able to serve and help support those ongoing operational considerations for your organization. Importantly, the regional health hubs will also serve as a liaison between the state MCO and providers to support implementation. So they'll serve sort of like a conduit of information in between all of us to help make sure information is free flowing, to make sure my inbox or Mike's or John's does not hold up your questions or process. They'll also be promoting the program to make sure we have a robust network of providers. We have 300 plus folks on here today, which is really exciting. But of course, I'm sure we're not connecting with everyone who might want to be a part of the program. So we're going to be really leveraging them to help spread the word about what this is and we should connect with, and also to provide information for housing support providers for who they should connect with, either at the state or MCO, to be a part of the program. And lastly, and perhaps most important, is the member engagement piece. So each regional health hub will be helping connect members to services and helping spread awareness of this program. While we, of course, are expecting the MCOs, you all housing agencies to be on the front lines and really spreading the word about this program. We, of course, want this program to be a part of the conversation for folks to be aware of what services exist to help them either obtain or maintain their current housing arrangement. So more to come on that. We're going to be actually having our first training in a few weeks. It'll be a Medicaid 101 training, and it will be pretty much like what is Medicaid, pretty basic stuff, but will help provide a nice foundation for you all, and then also provide some context on, you know, if this program makes sense for organizations to join. So a little bit deeper than what John went into on the first few slides, but that will be in the next few weeks. And if folks are interested in participating in the trainings and being part of the conversation moving forward, as Mike mentioned, please scan or click that link on the previous few slides or email myself or Mike or John, and we'll be sure to add you to the listserv. The trainings will be offered back up. So the What Medicaid 101 will be offered in the next few weeks. It'll be part of a broader training arc over the next several months. Each session will have different topics. So for example, the first session, as I just mentioned, will be Medicaid 101. Next section will be like, okay, how do I enroll with an MCO? Next section will be like, oh, how do I bill and submit a claim? Next session will be like, how do I become a good housing support provider and submit reporting requirements? So we understand this is a big lift and a big change for agencies. So we want to make sure we provide the necessary resources to make this program as successful as it can be. So I don't know, Mike, are you up now for questions, answers, or?
I have a bunch of questions, about
Okay.
14 of them for you all. But first, just wanted to say that there are comments saying it's very informative. The three of you are all very well prepared, and they appreciate this very crisp presentation. But it is fast. And so one of the first questions I answered several folks about slides being offered, which we've done before, but other folks are asking about a recording or transcript for this presentation.
I wonder if Michael might be frozen.
Maybe, it looks like it.
That doesn't bode well for our technology response to that question. I know we're good to send out the slides. I'm not positive about recording itself, but maybe we can when we send out the slides, we will
Right.
update
Address
on that answer. How about that?
Yeah.
Yeah,
Okay,
I know we went
so-
fast. I'm sorry. Some of
Yeah.
we
I
speak
think-
quickly sometimes.
Okay, there's Mike back. Yeah.
Hey, my apologies. I literally have the blue screen of death that just came up on my laptop. If you can hear it screaming
Oh,
in the
no.
background. So I had
Boy.
to pivot real fast. All right. Well, state technology. Gotta love it. Anyway, how we doing?
So the question was about a recording or transcript in addition to the slides being sent out afterwards.
Yes. So we will, if you joined and registered via the Teams instance, right, you'll receive access to the link. One of the things we'll also do, we will share, it is going to be way too large to share via email. So we will also send out via the state secure Dropbox, right, the MP4 version of this. Similarly, that'll also contain the transcript, Renee.
Great, thank you. So the next question that came up is the replacement of furnaces and hot water units covered under the services.
I think rather than specific answers to questions like that, this is a place where I'm a little nervous to say yes or no to something before we have our approved services
Right.
from CMS. I think you're in the right ballpark, but I don't want to say yes for sure or no for sure until we have that approval. So let's circle back on that one once we have approval, and that'll be part of the MCO and provider guidance documents that we're getting out in the fall.
So the next one is, do local boards of social services at the county level have a role in this housing supports work?
Well, there's at least one very direct role that I can think of, which is they play a role in our Medicaid members gaining access to Medicaid. So there's sort of a gating that we haven't quite discussed here, which is you do have to be a member, a Medicaid member, to access these services. there's two ways that could go. Either you are already one, or if a housing services organization encounters someone who they think is eligible, one of the first actions they could take to be able to access reimbursement through Medicaid is to get that person on Medicaid rolls. So there is a role there for the counties who do a lot of our eligibility work. I think there's also a lot of coordination and sort of making sure that the existing housing ecosystem and Medicaid are working well together in that area. In terms of like delivering services and reimbursement, I don't know that there is a role, but I would be excited to learn more if there is. Yeah.
The next one is about the clinical risk criteria and what is there a postpartum timeline after pregnancy?
You have nailed the ongoing conversation we're having with CMS. So yes, there will be, but I don't know what it will be yet.
And the next one is, do move-in supports include security deposits and realtors fees?
I am not sure about realtors fees. They will include security deposits. That's something that we can get back to you about.
Then there's a question about, what do you need to identify the types of services within those 4 buckets that you would like to provide when you're completing the LOI with the MCO, the letter of intent?
I think it would be good to indicate interest, but no, that's not a requirement of the LOI. I think it would be helpful to the MCO and the provider's relationship if you said, I am interested in pre-tenancy or tenancy supports, or I am interested in doing home mods, or both, just so they know sort of what bucket in their systems to be thinking about you in. But I think it's perfectly reasonable to say, I'm interested in it all, or I'm interested just in this narrow set. So not a requirement, but I think a good idea.
And the next question, there are a couple questions around this worded differently, but can an organization be a subcontractor or a partner enrolled provider to provide any of the services under the buckets?
Yeah, I saw this question come up a lot. There's sort of so many flavors to this that we have a hard time saying a blanket like yes to subcontracting, yes to partnership, that sort of thing. There are certainly instances in our existing networks where subcontracting or partnership works. I think this is a place where the provider guidance we're releasing, hopefully in the next month or two, will get into much more deeply the sort of branches of options that are there. It's not that it's blanket not allowed, but there's a lot that goes into whether a enrolled managed care provider can then sort of devolve the responsibility for the service delivery out of essentially the managed care network. So there's a lot that goes into that. Rather than a yes, no, I think I'll defer that one to the deeper guidance that we're going to release soon.
Right. There's another question that just came up that echoes like kind of an earlier question that came up a couple times. If an entity is a nonprofit and they provide housing services already, and they're also a Medicaid provider for other services, whether an FQHC or other type of medical provider, who should take the lead, or how will that work? Or are they eligible just in general?
This is one of those where if you are already engaged in providing Medicaid services, I think you're going to have a leg up in terms of knowing the process, already being connected to MCOs. I do not want to say you're good to go, because you are still going to have to join the managed care networks as a housing provider. And this happens in plenty of other contexts where a provider is an MCO network provider for a variety of, physical health services or something. This is another place where you will probably already have an NPI. You'll have some of the building blocks of it. So your pathway will be quicker, but you will still need to join as a housing services provider. So that's a place where some of the individual TA might be helpful, or once the managed care organizations have more guidance from us on their systems, they'll be able to tell their existing providers, okay, you need to do A and B, but not C, and you're good. So I think stay tuned for the specifics for an individual organization, but generally you'll be a little bit ahead of the game if you're already providing Medicaid services.
Great, thanks. And then the next question is about the reimbursement and payment for providers. So there were questions and I answered that there was a per member per month payment structure. Folks are asking a lot of questions about like what that means and kind of when will the information be available?
Yeah, we're working very hard to get those rates finalized. That's sort of the tough. I recognize that that is a very important piece in your all's decision that we just asked you to make around is this right for you or not? So we are working very hard to get those out. I don't have a timeline or a range or anything yet, but we are pushing. Our contract with the managed care organizations renews every 6 months, so we have a January update coming, and there are often rate conversations around that. So I'm hoping that we have some news soon on that. But I will say, generally correct, we're anticipating a per member per month for the pre-tenancy and tenancy sustaining services, and then a authorized reimbursement of cost on the home modifications or the move-in supports. And there will be limits to, per member over a certain amount of time, how much can be spent on home mods or how much can be spent on move-in supports. So that a slightly different structure there than the pre-tenancy tenancy supports. Pre-tenancy and tenancy supports with a per member per month, that is a member will be connected to a housing supports provider, and that provider will get the monthly payment for that member's support. There is an acknowledged sort of trade-off to that we are still working through guidance on for you. But if a member is bouncing between various housing support providers during a month, it's not like we're going to be able to fracture that per member per month payment. Then we're getting very close to the billing for a 15-minute service or something that was part of what we wanted to avoid in the design process. So with that sort of that hurdle acknowledged, that's how a PMPM will work, is that the member is assigned to a housing supports provider, and for that month, that is their provider for delivering those services.
Great. So the next question might be for Mike. If a Medicaid member is a victim of domestic violence, does the provider have to comply with HIMAS input?
Right. So this doesn't override any of the existing kind of MPP program structure or things like that of the existing kind of data governance of HMIS. But there will be some guidance coming forth from John Shop with regards to the his management system of record and things like that. So I would just put a pin in that for right now.
Great. And then there was a question about, can for-profit providers provide these services as they've been doing it for 10 years?
Yes, I don't think there's any prohibition on for-profit service providers joining MCO networks. I think there might be some nuances there I'm not thinking of, but no, I don't think there's any barrier there.
Yeah, they would only be excluded from the infrastructure grants we talked about.
Good point. So
Right,
yes, these
right.
grants that we're talking about are not open to for-profit institutions. Yep.
Thank you. And with the PMPM model, can two members in the same household be billed for?
So no, we will be billing by household. That sort of top line statement covers a lot of nuance. So you may have a household with multiple Medicaid members that are all eligible for housing services. We would expect the MCO to sort of designate a head of household and deliver the services through that member, which is not to say that everyone in the family doesn't benefit from the services, but we will be billing through one member of the household. There are instances, domestic violence is actually a good example, where maybe you would be delivering services to two separate members who at least initially, may be in a household. So there are nuances to that that we will get into in the provider guidance, but generally we're delivering the entire household services through one member.
And I think you answered this already, John, but there were a couple questions earlier about whether rates would be negotiated through the managed care organization.
That is how a lot of managed care works. We are not starting housing services in that space. We're going to work with our managed care partners to make sure that a housing provider is getting the same rate across the 5 MCOs. That may or may not be the long-term solution, but that is how we're going to start the housing services.
And I'll combine these two for you, Mike. There were questions about, is there any discussion at the state level around care and homeless services for non-Medicaid members? And then the second question was around whether vouchers would be available in the future.
Yeah, so I mean, what we're talking about with the portfolio of services isn't going to be voucher dependent. That's not a dependency for that. Similarly, I think more broadly, right, that this is starting a conversation, right, and kind of some deployment of strategy about how we're aligning some of those services to include those necessary gaps that are going to be very clear and apparent after this. But I don't have anything finalized to put out right now on that. So more to come.
Great. And then also there was another question about whether the supports would cover certificate of occupancy fees in addition to realtor fees that came in later.
Okay. Yeah, we'll get back on that one too.
Okay. And then another question is around, is there any professional credentialing needed for staff providing these services, or a degree like a social work degree? And I can help answer that if you want.
Yeah, you want to go first and I'll go
Sure. So it's not in place yet, but just launching this month. But we are embarking at DCA and the Division of Housing Community Resources on a nonprofit case management institute, which will encompass both housing case management and housing navigation services, which are part of these housing supports. So currently there's not a certification that exists in the state, but there will be within 2 years. And I'll let you go, John.
Yeah, so this gets very weedsy very quick on the mechanics of a provider organization becoming a managed care network provider, but the sort of shorthand is that providers will be joining at the organizational level, not at the individual human level. So it will not initially be the case that every case worker, every member of your staff will need to be credentialed with the MCO. The organization will be, and you will provide a roster of sorts. So as the certifications that Renee is talking about coming online, that's the sort of thing we would expect the staff to have, but we won't initially have sort of credential requirements at the individual person level.
And importantly too, I just want to make it clear to the providers that we did that on purpose, right? Is that we wanted to be affirming of both, right, the non-traditional paths of doing this work and the subject matter expertise that happens, and also to, if you're an LPC or you're an LCSW, and that's the and those are your credentials. Similarly, John, do you want to maybe talk about the deeming process too, because that might help flesh out a little bit.
That's a great idea. So one of the things we're working on to make this credentialing process smoother is to not only unify the process across the 5 MCOs, so it will be the same provider credentialing application for all 5 MCOs. We are also working on a deeming process where if you as an organization are already part of one of DCA or HUD's existing housing services provider programs, you will be able to skip a large portion of that credentialing application. We are a member in good standing of X program, and that skips over a lot of the questions that a credentialing application in Medicaid world would normally have around ability to provide services in a given service array. So we think, A, that's going to be a good way to streamline the application process, and B, make sure that we are engaged on confirming ability to deliver housing without having to go deep into each application and say, is this organization able to deliver high fidelity housing services? So you will see that application soon. That's coming out in the provider guidance in the fall, which I feel like I keep saying, but it's true. So you will see that application soon.
Thanks, John. Mike, there are a couple more questions about HIMIS. If a provider is not on HIMIS currently, can they apply for pre-tenancy tenancy support funding? And then there's another one, I'm scrolling down here. With the conversation on IT, what will the role of HIMIS be, I guess? Can the system meet the documentation required?
Right. So I say the first part, right? If you're a CBO that would like to explore, right? Getting credentialed with New Jersey HMIS, right? Of course, right? That would be an eligible cost. Although it's not that, the bar's not that high right now, so it's $1,000, right? But with that, right? We're going to be putting out kind of some additional guidance and things like that around HMIS and the partnership and what that's going to look like kind of moving forward. But so I would just put a pin on HMIS related questions from an operationalization standpoint for right now. Right, John?
Yep, I think that's right. Certainly encourage everybody to get connected, but requirements wise, more to come.
And I know we've gotten this question before, but Bobbin's asking about if there are two organizations handling different services for the same member.
Yeah, so if they are both, so if one is doing, say, pre-tenants, well, I guess they would both be in either the pre-tenancy or the tenancy sustaining bucket, but I guess the scenario is a provider is providing different pre-tenancy services to the same member, two different organizations, same service array. That is the conflict that I'm talking about here with the PMPM, where we will need a designated provider to be the PMPM provider for that month. That is not clean, and we're not entirely satisfied with that answer, but so we're still working to get further granularity below that, but that's sort of the working model of the PMPM, that we do need one provider. So there's instances where, and this touches on two ongoing questions that I think we're working on. One, designating a provider in a situation where a member is connected to more than one provider, and also the ability of providers to, that we talked about earlier, subcontract, coordinate, that's partner, that sort of thing. So those are places that we're trying to put out more guidance soon.
And then lastly, there's a question around whether recovery residences, rooming boarding homes, and respites would be eligible places for someone to receive housing supports and these services.
Let me answer that more generally than specific to those provider types. I mean, generally, if someone is providing, if a provider organization is providing the services in the housing support service array, and they would like to join a managed care network to deliver those services, I don't think there's a lot of bright line rules around, because you're doing, say, respite, you cannot do housing services. It's more about, can you deliver the housing services as we need them delivered to the members? So, sort of a turn it back around answer, but there's no barrier there that I can think of. It would be more about, you have to still join the network as a housing services provider in addition to your other provider network responsibilities.
Okay, and then someone's asking about the provider readiness grants. Are you okay with sharing when it will open and close, or?
Soon and after it opens? No.
Right.
We are racing to get it out there. I don't know, Michael, if you have a better way to phrase it, but we are trying to get it out there soon.
I would say be prepared for the opportunity to open within the next 4 weeks. Knock on wood.
Mm-hmm.
Right. I would say with that, and we will aim for at least a 35-day response time. So.
Great. Perfect. And then Bobbin has a follow-up question. If the MCO is doing the assessment of eligibility based on the member's health concern, I'm not sure why any housing support providers would need any specific credentialing. Am I missing something?
Any credentialing?
I
We might be using
think
the word credential in different ways, but go ahead, Mike.
Yeah.
yeah, I think there's a difference between I think Bobbin's worried about the staff credential versus the credentialing of the organization. I think differentiating between their two, and that's again why we're deeming the organization and credentialing the organization, not the individual level, because you're not giving a pronouncement on a comorbid diagnosis of, say, bipolar 2 with homelessness. It's the healthcare stuff is happening there, and the homelessness verification is happening at the organizational level to go and do so versus a actual. The other part of this too is on a more policy level, we are trying to work against the medicalization of homelessness, if you will. So there is that, and kind of a reason for the way that this is happening.
Yeah, there is a tension that I will absolutely call out between a health insurance program like Medicaid getting into housing to directly impact the health of the member, and therefore it sort of speaks to needing a clinical need, and the idea that, of course, you don't need a clinical need. If housing is an issue, then that is an issue for your health, regardless of the box that you check on the clinical list. So there is a tension there that I will just acknowledge and say, at base, we're a health insurance institution, and so we need some clinical tags
And
there.
we're at time. Do we have a few more minutes to answer a couple questions?
I have a
Sure.
hard stop. But
Okay.
okay.
All right.
Sure.
So I will take the questions and we will maybe try to answer them through the email follow-up or offline.
That'd be great. Yeah.
Okay.
Appreciate all the questions. This was great.
Thanks, everybody. And again, look out for look out for additional follow-on materials, all the read heads, everything else, probably in about 2 hours. All right. Take care.
Thank you.
Thank you
very much.